Thank you so much, Christine. I'm starting to get carpal tunnel here from all the hashtagging. There's like 30 different threads going on Twitter right now about this discussion, so that was very stimulating. Thank you, guys. I want to welcome any folks that have questions. We've got a mic right in the middle of the room. Please feel free to step up with questions. I have plenty of questions to take up the remainder of our time here. We will finish on time. 10:30 is when we end for break. Perfect. So where do I begin? I guess maybe if, Christine, we could segue from some of the conversation that you just provided us with. One of the questions that I've got here is you mentioned language. There's a change in guidelines around language that the media should be using. And I am curious about how effective that has been in terms of, have we had enough time to even measure? Has anyone looked at measuring whether there has actually been a meaningful change in what language the media is using? And the impetus for that question is that I know in the addiction space, in speaking with a lot of reporters, their editors are often saying, well, addict is a lot shorter to write in a headline than person with opioid use disorder. So how have you seen, or is there any literature to suggest that those suggested guidelines for changing the lexicon in the media has actually made a difference?
There's no studies to date that I'm aware of measuring that change in language. However, those of us who are involved in our day-to-day work are seeing the change happen. After Anthony Bourdain and Kate Spade died, for example, I will tell you that among the hundreds of interviews many of us did, a larger percentage of the conversations with media experts and journalists started with, help me get it right. I want to use proper language. Is a prevention effect even possible? We know about contagion. So there is clearly a progression going on with regard to awareness about that. It doesn't mean they're always getting it right, of course. But there does seem to be movement in that regard.
That's great. Thank you. And we've got a question from the audience. Yes, sir.
This is a question mostly for Dr. Wilcox. Dr. Wilcox, you presented data, the public health data, and we saw such a significant difference between genders. And I know that part of that is because men use more lethal means when attempting suicide. And so one of the questions I have for you is, when you look at just rates of suicide attempts, do those gender differences shrink? Do they even out? What might account for them if lethal means does not explain all of the differences? And then the second question is, if they do sort of even out, does it make more sense from a prevention standpoint to frame this in terms of suicide attempts and presenting data on suicide attempts rather than just completed suicides? Oh, sure. My name is Jonathan Duff. I work for a Congressional Research Service.
Thank you for your question. You see sort of an opposite pattern when you look for gender for attempts. So women having more attempts or reporting more attempts over time than men. And you're right, lethal means plays into it. Also access to treatment and women being maybe more open to accessing different types of treatments, and reporting, being open to reporting on those things is another issue. And in terms of your last question, which has to do with, is attempt kind of let me make sure I get this right, more of a useful thing to study, or would it be more useful to report?
Yeah, I mean, I guess looking at those data, it would make sense to target a lot of interventions at men just because of the subjects that show completed suicides. And I'm just wondering if the attempt rates are sort of hidden there, and if it would make sense to highlight those when we're talking about interventions that might be geared towards prevention.
Yes, and then one of the big things that we run into in terms of suicide prevention is that it's hard to show an impact on suicide death. You need really large studies and you need really large efforts with lots of people because it is still considered a relatively rare outcome. And so much of the work that you do see, and some of that I reported at the end, was work focused on suicidal thoughts, or as we refer to it, suicidal ideation or attempts. And many of the cognitive behavioral approaches that are quite popular in the field, and some of the preventive interventions that I reported on in schools and other settings and hospital settings, they do really look at impact of these interventions on suicidal thoughts and attempts.
Great, thank you. Next question.
All right, we have two questions from our online listeners. The first one is, in applying the systems approach, are there any findings or data on the physician level where mental health screenings are done during wellness or general visits?
At the physician level?
Does that mean, I'm hearing that meaning, can physicians learn to screen for depression and suicide risk? Or is it talking about impacting physician mental health?
I believe it's the first, based on the context.
So is there impact of screening on different outcomes?
Well, as it says, are there any findings or data, so when physicians, where mental health screenings are done during just general or wellness visits? I assume that means on suicide prevention or ideation.
Well, I can speak to data from the EdSafe study that in emergency departments that engaged in the screening practices of EdSafe, which meant universal screening to as much an extent as possible, what they were able to accomplish was a doubling of the identification of patients who were having current suicidal ideation or a recent suicide attempt. And that went from about 2.8% of an emergency department population in about 8 systems to about 5 point something. So certainly our first step is to identify those patients who are at risk, and then of course to apply the appropriate care steps.
And screening is kind of a controversial area for some people. It's, some people are really focused on screening, and there's a national incentive for it with the Joint Commission pushing for hospital settings to be doing these types of things in terms of early identification and recognition. And this, in some respects, you have to catch the person at the right time. They have to be willing to disclose. So screening isn't going to catch everyone at risk, for sure. But that being said, I find personally, from my experience, it to be useful because you do double the detection, and multiple studies are kind of showing those converging evidence that you can increase detection. But unfortunately, we're not going to catch everyone through screening because some people will not want to disclose due to stigma or due to other reasons such as that.
Elaborate on it a little more. Yeah, hi. This is Michael Schönbaum from the National Institute of Mental Health. The best evidence is on screening for suicide risk, I think, is what Christine invoked, which is not screening in general outpatient wellness settings, but screening in emergency care settings. So there are now actually multiple studies reporting on the experience of doing that. And the innovation, what the Joint Commission already expects emergency departments and hospitals to assess suicide risk in people who are presenting for psychiatric reasons. Mm-hmm. The innovation from the EdSafe study and also from the experience of that's been published from Parkland Health and Hospital System in Dallas. And there are other hospital systems and emergency departments that are also doing universal screening in emergency department settings but haven't reported on it publicly, published on it. What we know from the published research is what Christine identified, which is that when you screen all emergency department patients, you double the detection of people identified as needing care for suicide risk. EdSafe, the EdSafe study, also reported two other things that are noteworthy here. One is they had a phase of the study that involved only universal screening. They didn't also enhance care for the people that they identified. And what they found was that that the screening itself didn't move the needle in terms of subsequent suicide risk outcomes. You had to find people, and then you had to do some enhanced stuff, again, along the lines of these kind of simple follow-up interventions, safety planning, and follow-up contacts after discharge that Christine talked about in her talk. The second thing from ED-Safe that's worth mentioning in this regard is that they found that the patients who were identified because they were screened in the emergency department, as opposed to the patients that are identified via kind of the usual care emergency department methods, they present volunteering that they're ideating, or they present with injuries or other physical problems that a nurse thinks might be self-inflicted, that when they compared those two groups, they were statistically indistinguishable in terms of their subsequent risk, which is to say the people that you're identifying when you screen are real cases. They're not just answering the question lightly because somebody asked them. They're the people we need to be looking for. Just quickly, there is much less evidence, I think, so far about what happens in general outpatient primary care, let alone in well visits about screening. There's a now. It's dated. I don't know. It's not 10 years old, but it's something like that. A review from the U.S. Preventive Services Task Force about whether they should recommend screening for suicide risk in, I think, adult outpatient primary care. And they concluded that the evidence at the time of that review was equivocal enough that they couldn't make a recommendation about it one way or another.
That's great. Thank you so much for chiming in on that. Was there one more online question?
There's a couple. So
okay, perfect. So we'll take a question here.
Hi, I'm Linda Bieber from the American Psychiatric Nurses Association. We're about to equip our 12,000 nurses with community kits, and I was interested in the mental health literacy. We are sending them out with scripts and slide sets to educate the community in their own settings on things like mental health, violence, suicide, etc. But what I was intrigued about, and I'd love to hear a little bit more about, was the 93% of Americans who said that they would do something if they knew what to do. And I wondered if you could give us a recommendation, because we're also reaching out to the 3 million registered nurses in terms of educating them in more mental health literacy. So what would we what could we tell them to tell the public to do?
Sure. This is one of our primary messages to the public, actually, is how to respond to somebody you're worried about. And it's essentially a series of steps that we've almost scripted out about having a caring conversation. I know it sounds really silly, but when I realized that my physician colleagues really wanted it scripted to know how to approach a colleague in distress, we realized, you know what, parents need to have some language around how to talk to their kids or how to talk to a coworker. So we have all of that, and it's, I think it is as simple, though, as the type of caring conversation you would have with anyone in your life that you're worried about for any reason, but specifically setting a stage where you explain that you're there to support them, not to pass judgment. You're going to continue to support them. If you're a parent talking to a kid, I think it's really important to say, nothing you are facing, no challenge you're facing is going to change the way I feel about you. That expression of unconditional love is something that we often assume, and sometimes our behavior doesn't always stay consistent with, so we need to say it in that moment. So mostly it's about setting the stage of a safe, supportive conversation, and then it's also around how to address suicidal ideation and knowing where those 24/7 resources are and how to bring them to help. But the truth is, suicidal ideation is a very prevalent phenomenon. So we do not necessarily need to bring everyone who's having suicidal thoughts straight to the ER. Many people are living with that, with those. So that's part of the deepening of the literacy, I think, that also needs to happen, is the nuance around what to do and when to do it. And there's a lot of gray area there. But certainly, I think continuing to follow up and continuing to ask even after that initial conversation has taken place is important. There's one other resource that I'll mention. It's called Seize the Awkward. And this was an ad campaign that is in about maybe its end of its first year that AFSP and the JED Foundation, the Ad Council, produced that teaches young people, it's targeted to 16 to 24-year-olds, who value their identity as a friend. They know when their friends are stressed out and maybe even becoming at risk for suicide, wanted to do something but didn't have the language to do it. And so there's a whole toolkit around how to start the conversation, how to continue the conversation, how to come back to it. Don't take it personally if they rebuff you and things like that.
So could I ask a follow-up question to that, and then maybe we'll come back to the online questions? There has been a growing sophistication in the marketing space around product placement. And with the proliferation of social media, the use of mobile technology, it seems like there's more and more opportunity for it. As your organization, or is there any literature to suggest that we can better disseminate the awareness campaigns through not product placement, but through storyline placement, whether it's incorporating into a popular Netflix show or it's incorporating into, I don't know, some Zynga game, but almost normalizing the conversation around talking about suicide prevention and getting some of that scripting into what is just mass consumption of information. Is there anything like that going on right now?
I don't know about a science behind it, but you're certainly preaching to the choir, because that's what we do. We work with anyone who will work with us in the industry, including some major media people who have become interested, are lost survivors, are people with lived experience themselves, and just never knew how to work that into their creative content or their reporting content. So that is absolutely happening. I think it just requires the usual stuff of relationship development, of trust, and some empathy to understand the challenges that they're facing, and not being overly rigid. We have our parameters about safe messaging, as we should, but people aren't always going to get it right. So kind of still being willing to work with people as that relationship continues to grow.
That's great, thanks. And is there another online question? Great.
First, this is by Stuart Yale Gordon. Medicare covers peer support. Medicaid covers peer support. Medicare does not. Have you given any thought regarding to how to get CMS and/or Congress to cover peer support services under Medicare?
Yes, advocacy. We need that. And we would welcome any partners in that type of advocacy effort.
And there's a lot to sort out with peer support, just in terms of the training and the credentialing needed and the supervision of peers. And so in some respects, it's a really nice model, especially because there is reimbursement for it. But I think folks in the community are struggling with these issues that I just mentioned, of how best to train and how best to support peers, especially if they are in recovery. And so these are all things that hopefully will be sorted out as we move toward more towards implementing that model in communities.
I'll make just a quick comment on that. Medicare, once you get Medicare to pay for something, national reimbursement. Medicaid, state by state, there's 56 different flavors of Medicaid reimbursement. And so I'm not sure whether the source of that question is from an advocate in some locality or some vendor trying to get a solution covered, or a provider or a payer. But I would advise that while in the Medicaid space, if you get coverage approved in a particular state, that's all you're really approved for. It is less of a lift oftentimes to get one particular state to do something particularly innovative than it is to wholesale get an entire national coverage determination for Medicare reimbursement. How about that? And to conclude that thought, I'm going to tweet out a resource around how to maximize Medicaid coverage for peer support services in just a moment. Was there another? Oh, there we go. We have another
I
in-house
just
question,
wanted to
please.
respond to that. I'm also sitting on the Interdepartmental Serious Mental Illness Coordinating Committee, which is a congressionally mandated committee, and CMS is at the table, and the issue of peer support for Medicaid and Medicare has come up already, but it will continue to come up, and I will take it back to that table.
Wonderful.
That's great. We've got about 7 minutes left. Can I interject with one quick question? Because I want to make sure my digital health colleagues don't scold me for not asking this question. So a quick data point. Last year, there was $5.6 billion invested in digital health technologies. This year, we're on a trajectory to get to $6.9 billion of investment in digital health technologies. I heard both of you guys reference technology and the role of technology. I heard at least one catchphrase of data analytics or big data. And I didn't hear you say AI, but we could throw in all the fun catch terms. If we were to engage the venture capital community or private equity community or just angel investors and all the innovators out there to help us solve the issues that you guys just set this really helpful stage with, is there one thing that you wish entrepreneurs would turn their energy to and investors would turn their energy to that would allow for technology to augment or impact this issue in the biggest way possible?
Well, as I see it, the advances in this arena require truly interdisciplinary science and the use of what we currently know and being willing to experiment on some things that we don't know yet. So it's a new kind of way to do science. So I think investments clearly could be utilized there to motivate more of those disciplines to come together. It is already happening, but much more needs to happen. And when we could learn from some of the things that are going on right now, for example, at the VA with their REACH program, where they are using data analytics to analyze over 100 data points in the electronic health record and are doing active outreach to veterans, not just waiting for them to show up for their clinic appointment. That's a very progressive thing that's happening. And once we know more about how that's going, I think we could learn from that.
Thanks.
I think it would be great to be able to better utilize data in real time for intervention. And I alluded to this when I was speaking, the lag that a lot of it takes years sometimes to get the data from our medical exam or from community level data. And so it's hard to be able to use data for action if there's such a lag. Another thing that would be wonderful is to figure out ways to use social media data for intervention approaches, and I think that is an area of promise for great promise in the future.
Great, thank you. And we have an in-house question. Yes,
Hi.
please.
Yes, I'm Shannon Firth. I'm a reporter for MedPage Today. Dr. Moody, I wanted to ask you a little bit about, you spoke about physicians and preventing suicide or the stigma among physicians. Can you talk a little bit more about any efforts that are focused on physicians and how they may be different from regular people, how the stigma may be different among clinicians than it is outside of the hospital?
Okay, thanks for bringing my passion area up, and I'm going to try to keep it really brief because I could go on for a long time. Physicians are human beings who live in a culture, like many different people in other occupations, live in a culture where help seeking has been stigmatized, and mental health has been erroneously equated with impairment and not promoted in terms of having even safe to have conversations, let alone strategize for yourself to address a distressed colleague and things like that. So there are many, many changes happening along those lines at system levels, at local institution levels. I'll just give one example. The ACGME now requires that all residency training programs in the United States have programs for wellness and access even now to 24/7 mental health support for residents. So there's been quite a radical shift over the last about 4 years in academic medicine.
I have one more question along the lines of predictive analytics. I know there are difficulties in the EHR in terms of accessing information across different sectors of medicine. Can you talk a little bit about that and how that may make predictive analytics more challenging, or just make the information harder to access in terms of, Ms. Aiken spoke about how her father's EHR, if the EHR had been more connected, then perhaps doctors would have known one patient is on multiple medications or has had suicide attempts. Do you think anything is changing in that regard? Thank you.
I'll just really quick say that we're going to hear more about this from our Zero Suicide friends. This is what that's all about. It's about building a system that is integrated in a way that knows how to pay attention to the data points that matter, that indicate suicide risk, and that then people are trained in response to that not to communicate inappropriately with patients, as so often has happened in the past, but rather to show extra compassion and to make sure that that patient doesn't fall through the cracks.
One challenge that we face in our healthcare system and in many others is that what's coded can be used for analysis and can be used for things like predictive analytics. But oftentimes, where really important information are in the notes, which aren't coded. And so it's really challenging because information about their suicide risk could be in their notes, and it's hard for us to get in and access that in an efficient way. Not to say there isn't work being done in that area with natural language processing and going in and trying to mine through these notes and get the information needed, but it is a complex issue that's going to take some time to get all the technology sorted out to be able to do this on a large scale. And issues of privacy and protection of data are also major challenges in this domain.
Perfect. So we are up on time. I'm so sorry, but we're gonna. I really want to thank Dr. Moutier and Dr. Wilcox. Thank you so much for setting the stage. I think there's a lot more questions and a lot more discussion to be had. Fortunately, we have another day and a half to do all of that. So if we could have a round of applause, thank you so much.
Okay, really appreciate the work of the panel. That was excellent. We have a 20-minute break, and then we'll come back for our second panel. So enjoy your 20-minute break.